Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 24th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Anshima and Ms. Sandhya. Thank you both of you for joining. And Anshima, so it is actually our 74th episode overall. So this being the 74th episode, we have planned a new series, like a new concept for the 2.0 session. We're almost coming to the last few episodes. This is going to be the last second episode. So what is today's topic and who's our moderator, ma'am?
Yes, Gomati, I think we have been doing very well. We should pat ourselves and our students. This concept of going along with anatomy and then explaining the diseases has gone very well. Today, we are going to have anatomy of the orbit, and with us we have Miss Deepika, who's a postgraduate student from Agarwal's, and I'm very happy that she's working as a faculty now. So thank you so much, Deepika, for joining us today. We'll be awaiting your insights after the student finishes her presentation. So over to the MC to introduce Deepika in a much broader manner. So thank you, Deepika, for joining us today. Over to the MC of today.
Good evening, everyone. I'm Devjashwani, first year master's student at Dr. Agrawal Institute of Optometry. It is my privilege to introduce our esteemed moderator, Ms. Deepika Jayamurthy, ma'am. Ma'am completed her bachelor's in optometry from Mahatma Gandhi Medical College and Research Institute, Puducherry, and master's in optometry from Dr. Agrawal's Institute of Optometry, Chennai. Ma'am is currently serving as an assistant professor at Wales Medical College and Hospital, Chennai. Before stepping into academics, ma'am gained valuable clinical experience as an optometrist at optical outlets, and been part of many community and corporate camps. Deepika ma'am has a strong inclination towards research with multiple projects focusing on myopia, teleoptometry, computer vision syndrome, and ocular structural parameters in the South Indian population. We are truly happy to welcome you as our moderator for the day, ma'am. Thank you for joining us. The presenter for the day is Ms. Priyadharshini, first year M-Optom student at Dr. Agarwal Institute of Optometry. Ms. Priyadharshini, please start your presentation.
Thank you so much, Dave. Good evening to all. Uh, my name is Priyadharshini, pursuing Master of Optometry in Dr. Agarwal's Institute of Optometry. Today, I'm going to present about the anatomy of orbit. As we know, the orbit is a bony cavity which will provide a mechanical support and also have a proper position and movement of an orbit. So, it is more important to know about the clinical importance and also the anatomy of orbit. So these are the topics we are going to see in details. The first thing is about the shape and dimension and the walls of an orbit, which consist of four walls, and the apex of an orbit, which forms the posterior orbital margins, and the base of an orbit, which forms the anterior orbital margin, the paranasal sinus, where the infection spread more to orbit, and the periorbita, where the periosteum lining the orbit, and the orbital fat. So first coming to the introduction, the body orbit which lies either side of mid-sagittal plane of a skull below the cranium, which contains the globe, extraocular muscles, orbital nerves and blood vessels, and the connective tissue. It forms a four-sided pyramidal because the base of the orbit, which is located in the anterior part, which forms a four-sided quadriangular, and also the apex, which is lies in the posterior orbital margins. It seems to be like a pyramidal in shape. So coming to the bony orbit, by the sixth week of embryonic stage, the mesenchyme with encircling the optical vesicles, it forms a bony orbit. It is formed by seven bones, starting from frontal, ethmoid, and lacrimal, then palatal, then maxillary, then zygomatic, and the splenoid. So coming to the shape, it is a quadriangular and truncated pyramid. See the pictures, the anterior walls of an orbit. Anteriorly, it forms the quadrangular, and posteriorly, the walls of an object are converged and it forms like a pyramidal in shape. So, which is located above the anterior cranial fossa and below the maxillary sinus. It is a pear-shaped cavity where the stalk of an orbit is formed by the optical canal, and is also formed by the portion of seven bones. So coming to the dimension, the base of an orbit, which is the anterior orbital margin, it has a height of 35 mm and the width of 40 mm. And the depth of the orbit along the medial wall is 42 mm and the lateral wall is around the 15 mm. And the intraorbital width, which is the distance from the medial wall of each orbit, is 25 mm. And the extraorbital width, which is the distance from the outer, that is the lateral canthus of each orbit, is 100 mm. Then orbital index, which is more important because different ratios have different orbital index and dimensions. So orbital index formula is height by width into 100. It has the three components. One is microsense and mesosense and megasense. Microsense have an orbital index of less than 33 and megasense which has an orbital index of 83 and more. And the mesosense, which is a normal orbital index between the 83 and 89. And the volume of each orbit is 29 to 13 ml and it forms a ratio of 4:5:1. So coming to the walls of an orbit, which is more important. So there is a four walls. One is a superior wall, which is also known as a roof, and the inferior wall, which is also a floor, and medial wall and lateral wall. As we said earlier, so the apex of the wall, which forms like a pyramidal cavity. So each wall has a specific bones and relation and features and clinical importance. So first is about a medial wall. It is a quadrilateral in shape. This is because it forms a four-sided shape. So the medial wall of two orbits are parallel to each other and it will separate from nasal cavity by ethmoid and the sphenoid cavity. From anterior to posteriorly, it is formed by the maxilla and lacrimal bone and major part of ethmoid and splenoid. So the lacrimal fossa, which present anteriorly, which contain the lacrimal sac and continuous inferiorly, it form a nasal lacrimal duct. Medially, it is related to the anterior, medial, and the posterior ethmoid sinus. On the orbital surface, the upper part, which are related to the superior orbital muscles, and middle part, which is related to the medial rectus, and ethmoid nerves and vessels are passing through it. So as we said, the ethmoid sinus are present in the medial wall. So it is easily prone to infections like orbital cellulitis, and it is also known as a lamina pavericeae because of its thinnest wall. It is prone to blood fractures. So coming to the inferior wall, which is also known as the floor, it is a triangular in shape. It is formed by three major bones. That is the maxilla, it is a major part, and the zygomatic and the palatal bone. So coming to the features is more important because of the surgical procedures. The posterior part of the floor is separated from lateral for the inferior orbital fissure, and the inferior orbital fissures which continues anteriorly, it forms like a canal, and the canals which forms infraorbital foramen which transmit the infraorbital arteries and veins. So coming to the relation below, it is related to the both sinus. One is maxillary sinus and the palatal sinus. Above, it is related to the inferior rectus and the inferior optic muscles. So clinical importance, like a medial wall, it is also a thinnest wall. It can be easily prone to injuries and tumors and infections. So coming to the lateral wall, it is like the inferior wall. It is also triangular in shape, which has a three sides. And unlike inferior and the medial wall, it is the thickest and strongest wall. It is formed a 45-degree to the medial wall and perpendicular to the two lateral walls. So it is formed majorly by two bones, anteriorly by the zygomatic bone and posteriorly by the splenoid. So coming to the features, so on posteriorly, it gives rise to lateral rectus muscles, and anteriorly, it will give attachment to the stiff ligament of lateral rectus muscles, and posteriorly, it separates the roof from superior orbital fissure and roof with inferior orbital fissure. So laterally, it relates the temporal fossa and the middle cranial fossa, and medially, it relates to lateral rectus and lacrimal nerve vessels and zygomatic nerve. It is the strongest and thickest wall, where it only protects the posterior half of the eyeball because of its anatomical structure. So coming to the superior wall, which is the roof of the wall, it is also a triangular in shape which has a three sides, and it is formed by frontal bone and the splenoid bone. So anterolateral part of the roof has a depression called a lacrimal gland, which gives attachment to the suspensory ligament of lacrimal gland. So above the roof, it is little frontal bone of cerebrum, and below it consists of a periorbita, frontal nerve, LPS muscles, superior rectus, and superior oblique, and trochlear and lacrimal gland. So it is also a thinnest bone. It has also caused some mechanical injury, especially penetrating injury. And on the cranial side, the dura can be easily lifted because it's neither have nerve nor by blood vessels. So coming to the base of an orbit, as we said earlier, the base of an orbit which forms the anterior orbital margin, and it also formed by the ring of compact bone. So and also attached to septum orbitally. So the margins have four parts. One is superior orbital margins and inferior orbital margin and medial orbital margin and the lateral orbital margin. See the pictures, the superior orbital margins which contain the superior notch and the inferior orbital margins which contain the inferior orbital foramen and medially by lacrimal crest. So superior orbital margin is formed by frontal bone and with transmit the nerves and blood vessels of supraorbital, and inferior orbital is formed by maxilla and zygomatic bone. So medially it is formed by the frontal bone and the maxilla, and the laterally by strongest frontal and zygomatic bone, which is also strongest margins like a lateral wall. So coming to the apex of an orbit, as we said earlier, it is a posterior end of an orbit. The walls of an orbit are converged to forms like a pyramidal cavity. So it has a two orifice. See these pictures. It has a superior orbital fissure and also a optical canal. The superior orbital fissures which transmits more of nerves and veins, and the optical canal which transmits the optic nerve and ophthalmic artery. So below the superior orbital fissures, there is a inferior orbital fissures with it will join and it is contiguous with the foramen rotundum. So optical canal which connects the orbit to middle cranial fossa, and center it is a circular in shape, and the orbital end it is a vertically oval, and in a cranial side it is a horizontally oval. So enlargement seen mostly in the optic nerve tumors. So superior orbital fissures, as we said, it is situated lateral to the optic foramen of the orbital apex, and it is bound both by lesser and greater wings of splenoid, and it is a comma-shaped aperture. It has three parts. One is the upper part, middle part, and lower part, which will transmit some nerves and blood vessels. So upper part will transmit the lacrimal nerve, then frontal nerve, trochlear nerve, and superior ophthalmic vein. Middle part which will transmit the oculomotor nerve, which is the third nerve, and nasociliary nerve, and abducer nerve, which is the sixth nerve, and the lower part which transmits the inferior ophthalmic vein. So inferior orbital fissure, as we seen in the diagram, it lies below the superior orbital fissures between the lateral wall and the roof of an orbit. It will transmit mainly the branch of pterygopalatal ganglion, infraorbital nerves, zygomatic nerve, and the inferior ophthalmic vein. So coming to the paranasal sinus, around the nasal cavity, there is a air-filled cavities in the skull. This is from the sinus can spread easily because of the close proximity, and it is also known as paraorbital sinus. So the paranasal sinus has a four parts from each of the sides. So frontal sinus, then ethmoid sinus, splenoid sinus, and maxillary sinus. So it is divided into two groups from the anterior and posterior group. The anterior group which includes the frontal sinus, then maxillary sinus, only the anterior ethmoid sinus, and the posterior groups which is related to orbital apex and optic nerve, which include the splenoid sinus and posterior ethmoid sinus. So the important thing about this orbit is periorbita. So periosteum which lining the orbit, which is firmly attached to the superior and inferior orbital fissure, optical canal, and lacrimal fossa and orbital margin, and loosely attached to the bone. So any trauma and surgery may leak the CSF fluid, that is cerebrospinal fluid leakage. So its special features is on the posterior of a lacrimal slit, the periorbital is split into two layers, and anteriorly it can reunite. At the apex of an orbit, the periorbita which thicken and form a common tendinous ring, that is the analog ring where the extraocular muscles origins takes place. So coming to the orbital fat, so orbital cavity is occupied by the orbital fat into two types. One is from the optic nerve to orbital wall, and from the apex of an orbit to the septum orbitally. It is divided into two components. One is central and peripheral part. From the peripheral part, it is divided into four lobes. One is superomedial and superolateral, infromedial and infrolateral. So if there is any malignant tumors and infiltrative lesions can alter the orbital fat index. If there is any surgery, it can lead to better functional and cosmetic appearance. So surgical part, it is more important to know about the surgical parts. It can prevent the optic nerve and vessels injuries. So it is four components in this surgical space. One is subperiosteal space, peripheral space, and central space, and septenron space. So subperiosteal space which locate between the orbital bone and the periorbita, and it is more common of hematoma. and peripheral orbital space, which is lies between the periorbita and the extraocular muscles cone, and it is also known as extracorneal space. So central space, which is located in center of extracorneal muscles, so it is also called as intracorneal space, and which contains optic nerve, ophthalmic artery, and the cranial nerve. Then subtenon space, which lies between the sclera and Tenon's capsule, which allows free movement of an eyeball and also used for subtenon's anesthesia. So the coming to the last thing, so the clinical importance of an anatomy of orbitals, to know about the thinnest wall, this medial and the floor are prone to blood fraction which cause diplopia, and the disease from the sinus which can lead to spreading of disease more prone because of this proximity, and the infections from the ethmoid sinus which cause orbital cellulitis. And thus an orbital play a vital role in protecting and supporting the eyes, and knowledge about the orbit helps in early diagnosis of trauma, infection, and tumor. So these are the references. Thank you so much. I hope you understand the topic and get more information. Thank you.
Thank you, Priyadharshini. It was a very detailed presentation. So almost you covered all the points about the anatomy and the clinical features. So now I request our moderator to add your valuable inputs on today's topic.
Thank you, ma'am. It was a very clean and complete presentation, Priyadharshini. You didn't give me any gap to fit in, actually. So I just wanted to add few more points about the orbit. So since we saw the anatomical structures and all the parts over here, so orbit is not just an cavity. It is also an functional compartment where you can also use for protection of globe and which allows free ocular movements. Especially, it acts as a shock absorber for the nearby structures such as fat structures and all these components, and it is giving a cushioning effect during the trauma in distribution of impact of forces. So since you also mentioned about our medial part, how much thin it is, we do have a lamina where which is present in our medial wall, which is like a very paper thin like plate forming the main portion of our wall. Due to its fragile nature, it is very much prone to fractures, as you mentioned earlier. Not only fractures, it is also very prone to infections and spreading the infections along all over the brain, especially from the which spreads through the ethmoid sinus to the orbit and to the brain. So these are the factors which is very much important to know about when the thinnest part of the orbit is affected. So again, when we come to roof part, of course, the roof will be get more affected in children's, since the frontal bone is not fully developed. Either it can be frontal sinus either being absent or very small, or bones are more elastic than compared to other bones in the children's, which will come under green stick type. So these are the factors where the roof is much more getting affected for the patients in children's, and this may be a cause of like CSF leak or brain injury or any road accidents can happen, though these two parts are very more thin, as you mentioned already in your slide. And due to this, the trauma is transmitted to the orbital roof instead of the floor, since we are getting more roof damage in the children's over here. So the major factors we will see over here will be your proptosis, restricted eye movements, your diplopia, your eye swelling. All these conditions in ocular signs you will visibly see. When it comes to neurological sign, it is very much important to note whether we have CSF leak, clear fluid from the nose or the eye, or altered consciousness if brain is involved, or frontal lobe injury. All these things should be visibly noted. So these are the factors which will come under roof when we speak about roof. And of course, you have mentioned many way, like we do have blowout fractures. So blowout fracture, again, very commonest form of orbital structure, which includes break in the orbital wall. And whereas the orbital rim remains intact, the thin internal wall get fractures. So if I'm not wrong, according to our many researchers, the road traffic accidents causes 58 to 65% of the cases where we have our blowout fractures. A major red flag we have to note while studying all about this anatomy structure will be your sudden decrease in vision, your severe pain in eye movement. Either it can be inside the eye, either it can be outside the eye, your persistent diplopia, restricted EOM, proptosis, and so on. All these should be noted in case of any blowout fractures. So these are the points I just wanted to add. So other than it was an complete explanation about the anatomical structures as well.
Thank you, ma'am. Thank you for your inputs. And from students' perspective, we have few questions from student side. So, can I ask you those questions?
Yeah, sure, ma'am, sure, go on.
So, how does an orbital anatomy explain double vision? So, what is the clinical aspect behind it?
Okay. So coming to vision, normal vision requires both the eyes to move in a perfect coordination controlled by EOM. Along with that, all the cranial nerves, all such things. And as we all know, image falls on the corresponding retinal points to see a single image. If orbital structures are going to get affected, the eye is no longer aligned properly. Each eye sends a different image to the brain. That's how we are resulting in diplopia, double vision. For example, if you take inferior rectus entrapment, we will have difficulty in looking up, which will lead to vertical diplopia. So when we speak about diplopia over here, the fractured diplopia and acquired diplopia will completely differ over here. The diplopia which is getting due to trauma or mechanical restrictions will have different kind of clinical signs where the pain will be there, the eye movement will be restricted. We will have positive froze reduction test, and we'll have a restricted diplopia and up gaze limitations and sudden onset of pain after injuries. All these things will come under fracture diplopia, where we can easily differentiate from the other kind of diplopias over here. So the main factors here is, if the orbit is going to affect where the extraocular muscles are present over there, we will get diplopia over here. It's not only just because of the retinal things or the nerve path over here.
Yes, ma'am. Thank you. And we have another question. So, why does a blow to the eye causes a blow fracture? What is the anatomical aspect behind it? So, what should we look for?
Okay. So to understand about blowout fracture, first we have to understand about how the shape of orbit is formed. The shape of, let's keep it as a boning box. So, but not all the walls are equally strong. Since the orbital floor and medial wall are very thin, especially the floor formed by a maxilla. So when a blowout force like an ball or an fist hits the eye, the pressure inside the eye orbital suddenly increases. So this pressure get transmitted to the weakened area first. So that's how we are getting blows out fracture, as the name indicates, to release the pressure. So the major clinical thing here to understand is, if the inferior rectal muscles are getting trapped, then it can lead to restricted eye movements and double vision, all these things. The when again, we do have few more theories over here. So we do have hydraulic theory and bulking theory. In hydraulic theory, if the force hits inside the eye, the pressure increases inside the orbit and it's weaken the wall, which is a floor, and it blows out. When it comes to bulking theory, the force applied to the orbital rim is applied to the orbital rim, and the force transmitted backwards, and the fracture, and it can fracture the floor. So here we can understand that the hydraulic theory is more common and more accepted one. So since the thinnest wall is getting the force which cannot be equally spread when compared to the thickest wall, that's how we are acquiring our blowout fractures. If you take the clinical signs, you will have diplopia, especially in upper gaze. We have enophthalmos due to shrunken eye, which is due to the decreased orbital volume, or these can be the clinical signs of it.
Very well said. Thank you. Thank you for a clear explanation. So, that's all from my side. So, Anshi ma'am, do you want to add points to this?
I think Deepika and Priya both have done a wonderful job. So thank you so much, Priya. Very well presented. Thank you so much, Deepika, for bringing out the importance of small parts in the orbit. So I don't have anything extra to add. Maybe just to summarize, to for students to remember that medial wall is the weakest. It is prone to a lot of infection spread. And the floor is the one that gets commonly fractured. And as Deepika clearly said, that's when people start seeing diplopias. We also have to remember about the eye movements. So we are all follow this specific rule of LR6 and SO4, and the rest is 3. So which becomes essential for us to diagnose the cranial palsies. So key conditions which we have to remember when we are looking for orbital anatomy would be orbital cellulitis, proptosis, and cranial nerve related movement effects. So I think all this was very well covered by Deepika. So thank you so much, Deepika, for giving your inputs. And over to you, Gomati.
Thank you so much, Anshima. Priyadharshini, that was a wonderful presentation, Kana. Best wishes for your future. And Dave, thank you so much for being the MC. Sandhya, welcome for Optometry series. So let's continue to work very much stronger from now onwards to serve many more episodes to the Optometry community. And Anshika ma'am, thank you so much for joining. And our very own Deepika, we are so proud of you. Thank you for pitching in as a moderator for the day. We'd like to host you on another wonderful platform in the very near future, Deepika. Thank you so much for coming. Dear audience, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. The announcement for this particular week is it is a semester exam for all our students at Dr. Agarwal's Institute of Optometry. On behalf of the team of Optometry series and all the faculties and the team of Dr. Agarwal's Institute of Optometry, I'd like to wish them all the very best. And the announcement for others is the admissions are open for Pan India internship and fellowship programs at Dr. Agarwal's Institute of Optometry. If you'd like to know more about that, please check out the description box for the contact details. Meet you all in the next episode. Thank you all. Bye, team.